Assalamu alaikum. As you all guys know, today is our last lecture of the series of lectures of malocclusion given by the Dr. Naghman Zuberi. Without any wastage of time, I will like to invite Dr. Naghman Zuberi. Assalamu alaikum, sir. How are you?
Walaikum assalam. I am good. So actually, this is the last lecture on etiology of malocclusion, which we are doing for last. Uh, I think this is the third lecture. Yes, this is the third lecture in the last lecture. So let's start with this lecture, inshallah, and let's see how the things will go. So as I told you in our previous lectures that there were like different researchers and different authors, and they have tried to classify the etiology under different headings, under different categories. Like Graeber, he has classified under the general factors and the local factors. According to him, the general or extrinsic factors, we have already discussed about those, that the hereditary, congenital problems, then the environmental factors, then certain predisposing metabolic, climate, and other diseases like endocrine imbalance and metabolic disturbances, some infectious diseases, certain dietary problems like nutritional deficiency, vitamin deficiency, then abnormal pressure habits like abnormal suckling habits or thumb sucking, etc., etc. And then he had also classified under the heading of local factors or intrinsic factors like the anomalies of number, that supernumerary or missing teeth, then anomalies of the tooth size like macrodontia, microdontia, anomalies of the tooth shape, abnormal labial frenum, premature loss of the deciduous teeth, then prolonged retention, delayed eruption, abnormal eruptive path, ankylosis, and then dental caries and improper even dental restorations. Prophet tried to simplify the things, and he actually brought under the three categories: the specific causes, then the genetic influences, and the environmental influences. According to him, the specific causes: disturbances in the embryologic development, then the skeletal growth disturbances, the fetal molding and birth injuries, birth trauma to the mandible, childhood fracture of the jaw, then muscle dysfunction, acromegaly and hemimandibular hypertrophy. Then the disturbances in dental development like congenitally missing teeth, malformed teeth, supernumeraries, then interferences with the eruption, ectopic eruption, early loss of primary teeth, traumatic displacement of teeth, etc., etc. And the genetic influences, these are the mostly like a skeletal class 2, skeletal class 3, as well as the tooth size, jaw size discrepancies, which lead to crowding cases or to the generalized spacing cases. Well, the environmental influences, functional influences on the dentofacial development, masticatory function, sucking and other habits, tongue thrusting, and the respiratory pattern. Let's see the effects of genetics in dentofacial skeletal characteristics. Malocclusion basically is a developmental problem. Both hereditary and environmental factors, they have important influence on the craniofacial development. And it is really difficult to just say that either this malocclusion is because of genetic problem or because of environmental factors, or it is a combination of both. At the moment, we are not having these type of resources, I must say, that we would be certain that, okay, this is actually pure genetical in origin, or it is pure because of the environmental factors, or this would be a combination of the both. The relative importance of environment versus hereditary has been controversial even from the days of Edward Engel. The role of heredity cannot be ruled out. Always, whenever you will trace, when you see a patient of malocclusion, you trace the cause, and if you find out maybe their biological parents, one of those or both, or maybe some siblings, or maybe biological grandparents, anywhere in the family, or maybe some first cousin, they would be, or maybe some uncles or aunts, they would be having a problem. The role of heredity, as I said you, it cannot be ruled out. It is one of the main causes of malocclusion. In craniometrical and cephalometric studies of facial similarities, the evidence has supported the concept that facial form was mostly a product of the person's genotype, and therefore facial appearance seems to have a familial tendency. The method of superimposing lateral cephalograms of siblings on those of their parents to evaluate the similarities of craniofacial bones and profiles that revealed that there is a concordance for many craniofacial structures. Well, few studies they suggested that vertical parameters are more under the genetic control as compared to anteroposterior parameters. Like if a family is having long face problem or maybe an open bite problem, so maybe most of the members of that family are going to have the same type of problem. Or if a family is having deep bite problems, deep overbite, then probably most of the members of that family, they are going to have the deep overbite problems. So heritability seemed to be expressed more anteriorly than posteriorly, and mandibular shape seemed to be determined more genetically as compared to the mandibular size. The most frequent inherited malocclusion was found to be the facial deformity and open bite malocclusion with the dolichofacial pattern. The higher prevalence of anterior open bite was found among the black population as compared to the white population, and higher prevalence of deep bite was found among the whites as compared to the black population. Although the vertical parameters, they have more familial tendency as compared to anteroposterior parameters, but certain malocclusions which are caused by the sagittal discrepancies means anteroposterior, sagittal anteroposterior discrepancies of the jaws show a familial tendency. The influence of genetics on facial features was obvious in certain families, especially when we talk about the class 3 malocclusions. In most of the cases of mandibular prognathism, it have been accepted that multiple genes, they were involved, which means that the phenotypic trait is caused by the simultaneous segregation of many genes. But in some cases, this phenotype has been thought to be determined just by a single dominant gene. Well, genetic factor is there most commonly in skeletal class 3 cases. Similarly, mandibular retrognatism in skeletal class 2 cases is also congenitally controlled. Both class 2 div1 and class 2 div2 malocclusions, they have a polygenic inheritance influence. Well, malocclusions are also associated with certain genetic syndromes. Severe skeletal discrepancies are associated with one or the other genetic syndrome, and it is always accompanied with the malocclusion. Some of the genetic syndromes are known to influence the development of craniofacial complex. Chromosomal aberrations, deficiencies, transpositions, breakage, deletions, or enlargements usually lead to abnormal development of the first branchial arch, and we have already discussed about that. The maxilla and mandible, they originate from the first branchial arch or from the first pharyngeal arch. This genetic situation results in micrognathia, malocclusions, facial asymmetry, facial and oral clefts, oligodontia, and other dentofacial disorders, accompanied by different types of deformities and deficiencies in other parts of the body. Mandibular deficiency associated genetic syndromes are like Piri-Robin, very common problem in Piri-Robin, Treacher-Collin, and Marfan syndromes. Like if we look at the Piri-Robin, it is an etiologically heterogeneous disorder and shows autosomal recessive inheritance. An X-linked form also exists. These children, they have micrognathia and they have enlarged tongue, and in comparison to the lower jaw, it is so like a big problem that these children, they have respiratory problems, and even at times for the young children, like the neonates, we have to perform even the tracheotomy. Then comes the Treacher-Collins syndrome. Treacher-Collins syndrome is an autosomal dominant monogenic disorder caused by mutation in the treacle gene TCOF1, mapped to the long arm of chromosome 5. It affects the craniofacial development and expresses itself as micrognathia, hypoplastic zygomatic bones, and frequently cleft palate. Even the ears could be malformed as well in these children. Then comes the Marfan syndrome. Usually these children, they have long faces and they have very narrow arches. So Marfan syndrome is fibrous connective tissue heritable disorder, increased height, disproportionately long limbs and digits, mild to moderate joint laxity, increased overjet, rhypnognathia, micrognathia, narrow and highly arched palate with dental crowding, and at times there is even dentinogenesis imperfecta as well. DeCoster et al. Concluded that there is a strong correlation between the maxillary mandibular retrognathia, long face, highly arched palate, and the Marfan syndrome. Cleft lip and cleft palate, no matter it is only cleft lip, it is bilateral cleft lip, it is a complete cleft lip and cleft palate, or it is only isolated cleft of the palate. And no matter how early you repair it, still there will be a malocclusion associated with it. And these children, they need to see the dentist, they need to see the orthodontist, maxillofacial surgeon, and even at times plastic surgeon, and then the speech therapist and ENT specialist, like all the way up to the 18 years of age. They are even some of them beyond that. They would be requiring assistance from different fields of medicine and dentistry. Well, these patients definitely they have a problem, and even just simply doing the surgery and repairing the clefts and performing the orthodontics is not going to serve the purpose. The osseous grafts are always required. Otherwise, there will be deficiency in this area, and probably the treated cases are not going to be stable, or there would be again the clefts are going to reappear if the expansion is going to be done. So osseous grafting is also required in these cases. Then comes the fetal alcohol syndrome. Fetal alcohol syndrome is a pattern of mental and physical defects that can develop in a fetus in association with high levels of alcohol consumption during pregnancy. With time, this fetal alcohol syndrome children, they tend to have eye, ear, and dental problems. There is myopia, problems with the eustachian tube leading to the middle ear set the stage for ear infections. Then there is frequent malalignment and malocclusion of the teeth. Children with the fetal alcohol sequence or syndrome have enough difficulty in life without the additional burden of not being able to see, hear, and eat normally. These deficits should be treated appropriately. Behavior problems in these children are manifold, including unpredictable extreme mood swings, impulsiveness, diminished judgment, attention deficit, lack of normal self-discipline, irresponsibility, and difficulty taking social cues. If we look at these children on their face, there will be flat philtrum, no philtrum, and upper lip will be very thin. Most commonly, middle face, it is going to have a problem, not the upper one. Could be problem with the palpebral fissures. There would be some epicanthal folds, but usually from our point of view, the concern is in the middle face. And we can see that short nose, then they have the flat philtrum or even no philtrum, and they have very thin upper lip. Congenital absence of permanent teeth and ankylosed deciduous teeth. Most commonly, lower second premolars, they are congenitally absent. Like if we look into the details that which teeth are congenitally missing, so there would be second mandibular premolars, and they may cause a lot of problems, including over retained and ankylosed deciduous molars. And when we look at these over retained and ankylosed deciduous molars, there would be a chance that they would be now in over the period of time, they would be in infra-occlusion, and then there will be a collapse of the arch as well. There will be loss of the uh, arch length, etc., etc. Well, lateral maxillary incisors is the second frequently missing in number when we talk about the congenitally missing permanent teeth. So maxillary lateral incisors, they come number 2 after the mandibular second premolars. Well, hyperdoncia or supernumerary teeth, they also cause problem like maybe the mesiodam. There could be even multiple mesiodams. There would be chances of having parapremolars or paramolars or distomolars. They also contribute towards the malocclusion. Well, ectopic eruption, you can see over here, ectopically erupted tooth, and definitely it is also going to affect the rest of the dentition and will lead to malocclusion. Transpositioning or transposition teeth. Very frequently, transposition teeth are maxillary canine and maxillary first premolar. It means that they erupt in place of each other. They change the places. That is known as transpositioning. And definitely, it is also causing a malocclusion. Well, at times, the teeth, they are either they are lost because of some crowding problems, or they are extracted because of carious problems, and the tooth, they were like decayed. So they, whenever such a situation occurs, and if there is no already crowding problem, then the space maintainers should always be given. Otherwise, there will be a loss of space, and either the teeth which are not yet erupted, they will erupt ectopically, or they will be retained inside. We can see that there is an ectopic eruption over here. It is lingually erupted because there was no space for that tooth. Well, as I told you, I think in one of the lectures, that natural dentition, the deciduous teeth, they are actually the best space maintainers, and they should be treated and preserved until unless there is some like major contraindication in doing their endodontic treatment, like I'm not talking about the actual endodontic, the pediatric endodontic treatment, like pulpotomies or pulpectomies, etc., etc., and then providing the appropriate restoration in the form of extracorneal support, extracorneal restoration using the stainless steel crowns. Well, if there is a prolonged case of caries, you can see that over here, because of the prolonged caries, the teeth, they have migrated mesially, and there is definitely a space loss. Even faulty restorations, they will also lead to space loss in a developing occlusion. Thumb sucking and digit sucking, very big problem. If there will be a persistent thumb sucking, it will lead to anterior open bite, and even at times what happens, there will be a posterior cross bite and anterior open bite. If the problem is suspended, if this habit is suspended at an early age, there would be a chance that this anterior open bite is going to be self-corrected. But this constriction of the palate, it cannot be self-corrected, and it will lead to functional cross-bite. It needs to be tackled immediately. And whenever there is no matter posterior crossbite or it is anterior crossbite with a functional shave, the treatment should be initiated immediately, no matter it is a deciduous dentition altogether, or it is a mixed dentition, or it is an like permanent dentition. Whenever you see that there is this functional shift with the posterior or anterior crossbite, you should convince the patient and parent that treatment should be initiated immediately. Well, abnormal frenum or abnormally large frenum, they may have like many different problems, including even at times the gingival stripping and causing the median diastema. But it is not that you just see a large frenum with a diastema and you start doing the frenectomy. It is always advisable, first of all, check whether this uh, frenum, it is the causative reason for the median diastema or not. And in that case, you pull the frenum firstly outward and then upward, and then check the blanching effect. If there is blanching effect, yes, it could be a cause. But again, like 20 years ago, what we were doing, we were seeing just one large frenum and we were doing frenectomies, but that is not recommended now. It is better to close the diastema as well as wait for the canines, permanent canines to erupt, and then you will see if there is no chances of relapse, or you see that it is not going to cause any problem in future, then don't do it. But if you feel that still there will be a need to do the phrenoplasty instead of doing frenectomy, it is better to go for phrenoplasty, and we do the Z incision and all that, and then we do the phrenoplasty instead of just cutting the frenum like this. Yes, childhood traumas, they also are a major reason for uh, causing the malocclusion. Usually, children, when they get trauma and their TMJ is getting affected because of the trauma, then there would be a chance of developing the TMJ ankylosis. Well, if a child is reported to you with a trauma, then always keep them on regular recall and tell even the parents and child that if you feel that the opening is getting limited, then you must come even without appointment. Like if you have scheduled 6 months appointment and they feel that within like 2 months they are having the limitation of the opening of jaw, they must seek the appointment and treatment immediately. Your help should be given to them immediately. Always go for their x-ray examination, as well as you must check their facial appearance, and you must palpate the uh, lower border of the mandible. Ask the patient to open the mouth, and you can see that there will be a deviation upon opening. There will be definitely a limited amount of opening, but upon opening, the deviation will always be towards the affected side. And even on the X-ray, we can see the antigonial notch is quite pronounced because there is lack of development on the affected side, whereas the other side will be having normal appearance. You can also feel it when you palpate the lower border of the mandible that the affected side is going to have very accentuated antigonial notch. There will be facial asymmetry. There will be even asymmetry in the midline, and you can even see there will be probably developing crossbite as well, posterior crossbite. These people, these children, usually they go into class 2 malocclusion as well. Well, other than trauma to the jaw, trauma to the teeth also leads to the development of malocclusion, like intruded teeth, avulsed teeth, or uh, displaced teeth. At times, they could re-erupt, but if they are not re-erupting after a certain period of time, then orthodontic assistance would be required to bring them back into the occlusion. Hormonal influences are also very important, and that is why the growth chart, and you have to check out the child according to their age if they are growing properly or not. The reason would be maybe there would be dwarfism, maybe there would be some mild lack of growth hormone. There would be chance of acromegaly as well if they are continually growing, or maybe they have the gigantism or things like that. There would be chances of even thyroid problem. Hypothyroidism will be a major cause of developing malocclusion, delayed eruption, and similarly, in some of the children with juvenile hyperthyroidism, the eruption would be earlier than the uh, actual timing of eruption. So, over here, we have tried to sum up some of the etiological factors of malocclusion. And as I have already mentioned in the beginning, that at the moment we cannot be uh, like say with the confirmation that this is the reason or that is the reason. Whenever there will be some environmental factor, a genetic factor will always be there. So it is going to be expressed. Like most of the people with the oral breathing or mouth breathing, they do not develop the malocclusion. While when we see a typical case of long face and we see that there is a class 2 with long face, if we take the history, we will find out, yes, this child had adenoid problems in the uh, beginning, or they had like tonsil problem and breathing problem, and that's why they were mouth breathers, and the problem has been developed. Usually, the local factor that is always having a problem with the genetic factor as well. Yes, missing teeth or congenitally missing teeth, or the premature extraction of the primary teeth, that could have only and only the local factor. But in most of the cases, genetic influences is still there, and a lot of research would be required to find out the actual basis why which factor is affecting. So, any questions? Definitely, I will have to answer those questions, and we will definitely continue with other lectures as well for you. Any
Okay.
topics you would like to uh, go through with me, let me know, let the owner of this channel know, and we will definitely make a lecture on that, and I will be back with some other topics as well. So thank you very much.
Thanks a lot, sir. Thank you. Khuda Hafiz.
Khuda Hafiz.